So yeah, so we might as well jump into it. I think we'll get some more people jumping on too. Um, Sorry, I just got home here. Um, but I wanted to add some discussion with Rob and a few others about the whole blood flow restriction thing. And I don't know much about it myself. I thought a tourniquet was after a snake bite. That's about it for me. Um, Tommy Christian, have you ever restricted any blood for any reason?
Not intentionally, no.
No skateboard accidents or anything like that where you've
Yeah,
had profuse bleeding?
not yet.
Not yet. Okay, good to hear. So this idea for using it for, I think primarily I was brought to my attention by Rob, was for rehabilitation purposes, but I think some people are using it for performance or muscle hypertrophy, for maybe even aesthetic reasons. I don't know. Again, I'm not an expert. I'm just a facilitator. And so we'll get some of the people who've been using it in practice to chime in on some of the questions that I have here, and some of the basic ones I think are, what are you using it for, and what are the key applications? And so I'm going to start with one of the birthday boys, Anthony. He was highly recommended by people who I won't mention. So, but Anthony, you want to start us off and give us a bit of background on what you've been doing with the blood flow restriction, and how you think you can use it to your advantage?
Sure, certainly. So I'm a physical therapist working in the Washington, D.C. region. So we see a lot of return to sport, a lot of post-surgical. So the big, if you look at the research for BFR, the big takeaway is that for periods of immobilization, we know we lose muscle mass extremely quickly. So you see a 30% decrease in muscle protein synthesis and 10% loss of muscle size, which is like you can lose up to 30 and 50 grams of muscle over 2 weeks of immobilization with a 30% loss of knee extensor strength. So we know immobilization is a huge issue very quickly. What they've shown is that by doing the blood flow restriction, we can create a stimulus that can help to preserve a lot of that strength and a lot of that muscle. So really the big key point of that is early on in the process, when we can't load, the BFR is sort of a backdoor around having to load. So we find that we can get around with 30% of a 1 rep max, we can simulate around an 80% of 1 rep max type stimulus to the system. So really for us, it's a way that we can do a high intensity stimulus when the body is not ready to handle that type of load.
What are some of the key areas that you've been using it on, areas of the body that you would say like are kind of a no-brainer for you?
Really anything lower extremity. So if I'm working with somebody with, post-op Achilles, post-op ACL, really anything where we're loading that upper extremity works as well. It's just a lot more uncomfortable for people, I find. And we see a lot more heavily loaded on the lower extremity injury post-operatively. So that's kind of what I've played around with it a lot more with.
Okay, interesting. Okay, let's bounce it around a bit here. Rob Panarello, I know we discussed this, and you have done a lot of research into it, particularly for your clinics and your clinicians. What are some of the things that you found using it? What are some of the things you're using it for? What are some of the benefits you've seen?
Yeah, we use it in the same way Anthony has described. I've not used it in performance. I'm using it in rehab. I look at BFR as just another tool. We use it mostly in the acute care setting, post-ops, or you can use it, with prolonged atrophy. Some people maybe a year post-op that haven't regained full hypertrophy of what you'd like them to be. The one thing that I believe it doesn't do is, I think, and people ignore, is you've got to be able to react to the ground, and you've got to be able to have a stretch shortening cycle with regards to a lot of high velocity movements. And, we held a course with the Owens group, and I relayed that question to our instructor, and they agreed that you do need load. It doesn't do much for tendon. And so it's important to have hypertrophy of the muscle because you want to have muscle and joint stiffness to get a good stretch reflex, but you still need to get people on their feet and load them because you don't want to compromise the tendon as well. And a lot is, in my opinion, having these discussions, no one speaks about tendon, and it's a key entity for performance. So I think it's just part of the process. I think it's a good thing for the process.
Oh my goodness.
We're doing a study with HSS right now, Hospital for Special Surgery, and Dr. Dracos in conjunction with special surgery on Achilles tendon repair, because his big concern is atrophy of the gastroc. And he's having some pretty good results to it. But, you know, I think it has its role and its place. I think once you get out of the acute to intermediate phases of rehab, you've definitely got to get people on their feet. You got to start loading them.
So say in an Achilles rupture and a surgical repair, how quickly are you doing this after the surgery? Like, what's the timeline on something like that?
Probably 4 to 7 days, depending on the patient.
Okay. And yeah, because I just recently saw somebody post Achilles surgery, and how much that calf has shrunk was just amazing. You know, so definitely something like that would be useful. Okay, let's jump around some more. Jordan, do you want to talk a bit about what you've been doing with the method, the concept?
Yeah, well, as we always go with that, I agree with what Anthony and Rob said earlier. I've been using it similarly, so mainly for rehabilitation, especially in individuals that can't load yet. So either someone post-operatively or someone pre-operatively. I was talking to Anthony the other day about pre-op, and out here in Montreal, it's sometimes a little bit longer for people to get their surgery. So it gives us, sometimes it's actually positive. We kind of have more time to do certain things pre-operatively. So I've been using it for that, and I've been using it a little bit also for more people that had pain, so something like a patellofemoral syndrome, so basically knee pain without a clear diagnosis. And I've had a success with a few people that have had like different or weird knee situations and that don't respond well to load, and the blood flow restriction seems to help with making them move with less pain. I know Anthony, I think, has been playing around with that a little bit as well. That's mainly what I've been doing. I've done a little bit of blood flow restriction. Again, mainly it's been post-operatively, and I've also done it with a few circus performance performers here from the Cirque du Soleil who had basically had some issues with regaining muscle size after multiple surgeries or injuries. And as to what Rob was saying, what was interesting with them is that what we would start with regular training at first, trying to load them up a little bit more, trying to load the tendon, working on elastic responses, and doing some blood flow restriction work later in the session as almost like a kind of like an accessory, and just to add a little bit of volume and work on getting a little bit more muscle size.
Okay, I'll get Nikki to jump in. Nikki, as the resident chiropractor, what are some of the things, and just general rehab professional, what are some of the things you're doing with blood flow restriction?
Yeah, I've been doing concussion prevention, so I've been using it on the neck of certain patients. That's a joke, by the way.
The neck tourniquet. Okay, nice.
The old neck tourniquet, like the woodpecker. Increase that intracranial pressure. So actually, fairly similar applications. Been quite interested. So I actually know Johnny Owens and some of the guys that instruct for Owens quite well. So have also been using it for analgesic purposes. So we've been working with a few athletes, so pre-game, pre-training, instead of using isometrics, for example, with tendinopathies. Using that, combining it with electronic stimulation, with e-stim, also to try to induce hypertrophy. So we've been looking at various different applications. Failed rehabbers, so people who've been through rehab maybe quit because they weren't getting good results, that have got pretty major strength deficits, even motor control deficits. Sometimes it's just a little bit of a stimulus to give them a little kickstart and get them back into a regular routine, because if nothing else, it makes them feel like it makes them feel like they're going to failure. So from that point of view, they feel like, oh, I haven't been able to work that hard for a long period of time. So sometimes it can just also be a motivational factor. I mean, getting away from some of the physiological changes that seem seem to be occurring with the modality. And also I think it's just worth sort of pointing out there's, I think, in excess of 900 papers now published on the topic. So there is, I think, a volume of work now going into tendinopathies. There has been a reasonably good volume of work in terms of maintenance of muscle mass and hypertrophy, and I think also strength training with very low load exercise as well. One of the other parts that's been quite useful recently is also using it with endurance athletes, potentially with a view to making alterations to VO2 max. I haven't obviously measured that, but again, throwing it on there for 50 minutes and getting a bout of aerobic exercise, we can get the hypertrophy effect, but we can also potentially increase cardiac output through that decrease in stroke volume. So without wanting to, I mean, I'm a fanboy. Like I really like the modality. I think it's changed a lot of what I'm doing. But it's, I mean, obviously it's not a panacea, as they say, but just what a wonderful adjunct to have, especially for somebody with limited space. I mean, I know Derek, you like to work also in a phone box or in a jail cell, not in a jail cell, in a phone booth, let's say. So it's something you can get a fairly comprehensive training session done without necessarily having access to good weight. So just really being a fairly ubiquitous tool that I've used across a number of different situations.
I was going to ask, we'll bounce it back to Anthony. Can you guys get into a bit more discussion of what is happening physiologically? Like I've heard different things, and I was talking to one doctor about, he just thinks it creates a hypoxic environment, and then there's adaptation from that. But Anthony, what would you say is physiologically happening at the muscle level, the blood level?
Sure. So there's 6 main physiological characteristics that are being adapted through the BFR. So really, if we think about that pressure creating the shunting effect and creating the metabolic buildup, we get, number one, we get metabolic accumulation, which creates a uptick in growth hormone. A lot of people will kind of go nuts over that increase in growth hormone from the BFR, but it's really no different than what you'll get from regular conventional strength training. But as we said, if we can't load greater than 80%, this is the backdoor around that to get a similar, metabolic profile that we get with typical training. The second thing is just for getting muscle fiber recruitment. So if we are decreasing the amount of oxygen available, we're going to fatigue the type 1 fibers a little bit faster and get type 2 fiber recruitment, which is harder if we can't load to a higher level or load with any sort of speed or velocity, which is really hard in a immobilized or low loading type situation. The next thing is there seems to be a pretty large uptick in the mTOR pathway with the BFR, which is, again, similar to what we'd see with regular strength training. We'll see stimulation of heat shock proteins. We'll see the NOS1 nitric oxide kick up, and then we'll see a decrease in myostatin. So there's a couple of different physiological things. And really, when you look at this, and I think we kind of, I know when I first learned this, got caught up in some of this stuff, but if you look at it, it's really the same thing that's happening when we're just doing regular weight training. So I don't know if it's magic anyway physiologically, other than we're just creating a stimulus similar to what you get with high level loading.
Do you think there's, again, I'm just thinking ahead here. Do you think there's some people who think, well, I can get my weight workout in, and then when I'm at home and I'm eating my noodles or whatever, I can do this and I can stack these things on each other? Would there be an overtraining effect if you're not careful with this type of thing?
So I think that's one of the benefits to it. And if you look at that in like using it with a healthy population, where it's a way to get this metabolic uptick without the same level of potentially neural fatigue, because we're getting kind of a localized physiological input without having to go through this high level loading that would stimulate the nervous system. So as an adjunct to regular training, if we're looking for increases in hypertrophy or looking to keep a elevated, anabolic profile, it could be effective there.
Interesting. Rob, I mean, do you have therapists using this across the board in terms of different types of patients, whether it's athletes or maybe even elderly people? Like, what have you seen?
Well, I haven't used it too much with elderly. I have a particular precaution with regards to cardiac conditions, etc. If they have clean bill of health, then we'll make an attempt. We have used it in total joints sparingly, admittingly. Yeah, we've just been playing on this for a few months now. It's not like we're experts on it. Think, the thing I just say is I'm a big believer in that you need load. I think that the rest of the body responds to load. I think this has a place in regards to, and again, I've used it in performance, so there may be others out there that have had great success in regards to performance. I just think when you load, you just have an effect on the rest of the body. I think that when you load, you help assist with things like kinesiophobia and getting, people who are afraid to load, you help resolve those things. I think with BFR, you exhaust, you're going through isolation and you're exhausting, whether it's the low extremities, et cetera. And there are studies out, and I don't like to train or exercise after exhaustion because bad things occur when you're exhausted and you try to move, right? Kinesthetics, awareness, proprioception, biomechanics, technical proficiency of performing an exercise. I mean, there are studies out there where you exhaust a normal shoulder, a normal rotator cuff, and it can't offset the polar deltoid and that rotator cuff deltoid force couple. And so if you exhaust a normal rotator cuff, the head of the humerus will migrate in the glenoid the same way the head of the humerus will migrate in the glenoid with a torn rotator cuff. So I'm cautious with doing anything after exhausting somebody. And that's what happens with BFR. And I'm not big on loading after someone's exhausted for the same reason. But I do believe, and there's studies out there, you'll have increased effects of hypertrophy with BFR, but there are studies out there that even though the muscle fiber has a larger hypertrophy measured effect due to BFR compared to traditional strength training, the strength levels are greater with high intensity loading versus BFR. So again, I think it's just part of a process where the tool fits the need. And for me, it's in the acute to intermediate stages of rehab, unless you have someone that, as mentioned before, they had rehab somewhere else, they come back, it's a year later, and they still have this skinny limb or whatever it may be, and then it's a tool to try to promote hypertrophy.
Yeah, there's a couple of questions here I'll try to rifle through. There's a question on BFR versus electrical stimulation, and I'll kind of open it up. But I know in my use of electrical stimulation, I can usually get pretty good strength and recruitment numbers, but maybe not the same on the hypertrophy side in terms of cross-sectional area. But it sounds like some people may be using both. Anybody want to comment on that? Just jump in.
Yeah, so a lot of cases, especially in early post-operative cases, you're going to use the e-stim with the BFR, so you can kickstart that process a little bit earlier without weight bearing. So it's definitely not that wouldn't be an either or. They can be used together. And I think with regards to load, I mean, Rob's right, and there's certain adaptations that you can't get from BFR. So I mean, I think the idea of BFR is to allow somebody to maintain a certain level of muscle mass until they're in a position where they're clear or ready to actually start to load articulations and other structures, maybe where they're neurally better prepared for it. So it's really a stopgap from that point of view. But it really does work well with EMS, and part of the reason is, I mean, I think when you're using e-stim, you're getting a higher level maybe of motor unit recruitment, but also one of the effects of BFR, because the anaerobic effect on it, the fact that it pushes you anaerobic, you've got the sort of inhibitory effect on the local muscle fiber. Well, then you'll start to get synergistic recruitment, and you'll actually get a larger number of motor units recruited. So there's probably a cumulative effect there also when you're using e-stim. And again, it's just a great way to go if somebody's not quite ready to load, but you want to start pushing a little bit.
Thanks, Nikki. We got a question here from Huawei Mate SE, which I just want to tell you, Huawei, once you start in here, the U.S. government will be monitoring your response here. There you go.
Hey, can I speak?
Yeah, you can.
All right. It's my name's Greg Hawthorne. Sorry, I don't know why
just bugging you.
But I already know the fact that I monitor everything that I'm saying because of my I already know this. So I've been using BFR for a while, and I kind of been using it a little bit differently ish. But I've been looking at, I know a gentleman by the name of Bill Hartman. And I've been to the intensive, and his thought process when it comes down to kind of looking at the body in regards to like, tubes and, fluid fields and, all that other physics stuff, has got me really into looking at BFR and muscles in that aspect, in regards to, essentially I look at the muscle as, hey, we're just trying to put fluid in it to make the contractions occur and things along those lines. So essentially, hey, I'm pumping fluid in my legs to kind of make them straighten out. On King of Hose. And at the same time, if we look at the idea of the tendons and the connective tissue, I think that's where BFR really plays a big role as well, for me. So someone who's like, when I've been utilizing it extremely well with essentially insidious, if you will, hand, elbow, lower upper extremity, and calf, ankle, or calf muscular pain. And essentially, I look at it as the expansion that occurs within the connective tissues of the muscles. Essentially, the BFR helps me essentially create more of a less stiffness within the connective tissues, which then helps with the for myself a lot of pain and a lot of the ability to a comfort level, or essentially get the blood flow moving back into, so it decompresses essentially the area through the buildup of fluid within the muscle itself. And then that also makes sense for me when it comes down to like the performance of things and why you're going to have a drop off with that performance, because now you have a decrease in the stiffness of the tissues. And so essentially the tissues themselves kind of become more of an eccentric oriented, if you will. So they'll have more of an expansive property. So when you try to contract that tissue faster, it's going to expand more than it would if it was more, I guess, less, if it was more stiff. Does that make sense? But I have had great results with BFR in regards to, again, like I work with a lot of mechanics and basketball guys, so there's a lot of calf stuff for the basketball guys, and a lot of upper extremity stuff for mechanics, and especially forearm. It has helped those guys who kind of gone too far in the rigidness within their tissues, and in utilizing it after 2 or 3 sessions, is that the pain drops significantly and their function jumps way up, and essentially their ability to perform their work for long periods of time jumps way up as well.
Interesting. Anybody want to comment on that? Jordan, do you have any thoughts on that?
Yeah, I mean, it's that's what I was alluding to a little bit earlier, and I don't know if there's actually one recent study on hypoalgesia and BFR, and then they talk about a few different mechanisms there, which I found interesting. So I've been thinking a little bit more about that and about how it can be used. With regards to tendinous adaptation, I don't think that that's necessarily what I'd look for, at least from my understanding of it right now, when I do it. But I do think that it can help with regards to not causing pain and potentially having an effect on basically the inhibition that you would get associated with the pain. So I've had a little bit, as Greg mentioned, using it on people that have anterior knee pain, for example, and being able to load them to a very serious level while they had the blood flow restriction on, whereas without it, they would be symptomatic a lot quicker. And my understanding of it was a little bit similar to what you mentioned. So basically, instead of having all that load into the knee and the knee not responding to it or being sensitive, basically redistribute the load to the whole limb, because the occlusion happens. Basically, you put it as high as you can in your groin, as high as you can, close to the hip. And I've been having some good success with that. So I do think there's something interesting there, but I don't know enough. I don't think it's been looked into enough also with regards to studies to have something to quote on that, other than that hypoalgesia study. So that's mainly what I think about that. And as to your previous points, I have used it with EMS, mainly post-operatively. And again, I don't know if I obviously can only speak for myself. We obviously we're here talking about BFR solely, but it's not something that I'll use. It's something that I'll use with a few select people, and there's still, I think, the show, as some would say, is still loading them, getting them back into, stiffness drills, elasticity drills, and so on. For me, that takes place. The BFR takes place with someone that can't load it, and they have a hard time to do it, or we can't load them with a lot of volume, as Anthony was saying earlier, in which case we would start them off with regular training, mock drills, whatever else we need to do, and whatever else they can do. And then maybe at the end of a session, in order to, so that they don't have this fatigue in them, I would put it on them in order to get just a little bit of extra stimulation and try to get the muscle to get a nice pump. People like that too, right? They feel like they're working. So
Yeah, I mean that's the whole thing for me is whenever somebody brings up a new concept or technique is like, okay, where does it fit in? How much time do I contribute? Like I'm a camera guy, I get a new camera, I take all my pictures with that camera and I forget I have these other ones that work really well too. So does somebody want to comment on that? Like how, I mean, obviously we've talked about post-surgical and some specific injuries, like, you know, it's probably easier to notch it in within that treatment protocol. But if you have somebody who is a, like we talked about, a basketball player who has maybe some chronic stuff, you know, has to get strong, you know, it's part of their routine. When, how much, how frequently, how many times a day, like, you know, because obviously this can run amok if somebody says this is my new thing, my new toy, and I want to use it all the time. Does anybody want to chime in on that in terms of, like, you know, for lack of a better word, the periodization of this type of stuff? Anthony, we'll throw it back at Anthony.
Sure. From what I've seen and the conversations I had when I was doing the course with this, is that kind of stuff was all over the board. I think it kind of, a lot of people are using it in an N=1 type environment where see what works for the person, see what the situation is. If it's, you know, if it's somebody in a high performance, you know, NBA setting where they're getting so much loading going on during the course of the season as an adjunct, if they need to still keep getting work in or getting some other loading in, maybe that's a good way to get some of that volume in with less overall intensity. But that's not really the environment I work in, and I haven't used it to that, so I can't speak on any sort of personal basis on that.
Okay, Rob, do you have any thoughts on that in terms of just working it in how much and what?
I haven't done it. I haven't done it again like Anthony. I haven't used it in performance. I look at it in regards to the factor of, do I have such atrophy regardless? Like I said, it could be a week post-op, it could be a year post-op. And what am I trying to do? I'm trying to use another venue to induce hypertrophy, right? I'm exhausting my type 1 fibers to try to recruit my 2B/2X fibers so that I have a contribution of the muscle belly as a whole. And through this anabolic effect, for lack of a better term, I'm hopefully going to stimulate some type of hypertrophy to the point where, and that's where I think we're getting, in my opinion, that's where I think we're getting the analgesic pain, as mentioned before. We're recruiting more fibers within the whole muscle belly, which creates more joint stiffness, which unloads the joint, right? If you get somebody who has knee arthritis and you get them stronger, they feel less pain because you've unloaded that joint because of the increased strength and hopefully hypertrophy, et cetera, of the whole muscle belly contributing. And so that's when that's how I use it. It doesn't have to be immediate post-op. It just has to be in a situation where I want to induce hypertrophy. And as mentioned before, maybe fear of loading, or I don't want to use a lot of loads for whatever circumstances. We'll use it 2 to 3 times a week. I don't like to use it more than that because, again, we're taking people to exhaustion, and I want to make sure they can replenish their fuel tank, so to speak, before the next training session, wherever it may be. I don't want to keep draining something that eventually it's empty, and then I've got real problems. You know, the example I gave before about the shoulder, I believe it could occur at any joint, right? We throw things off. So, you know, that's how I use it.
Okay. Eric Marriott, you want to jump in? You asked a complicated question there, and I'm not the sharpest knife in the drawer. What are you saying? Ischemic preconditioning protocol. Could you elaborate on that?
Sure, I can elaborate on that question. I've done the Owens Recovery Science course, like it sounds like some others have been in the panel as well. And I know that the unit they use there has a built-in IPC protocol, which is a passive protocol. It goes 5 minutes of full occlusion and then 5 minutes of reperfusion for 3 cycles. I haven't used it as of yet. My question was sort of querying if other people had in their experiences, because there's supposedly some evidence out there for recovery. One study in particular where they did 200 eccentric loads of the quad by depth jumps and of various other plyometrics. And then one group sort of left to recover on their own, and one group did this IPC protocol and found a variety of things, including decreased sort of physiological markers and an earlier return to strength. And then, so for me, in terms of BFR, this is the thing I was considering in terms of using it in sort of this other domain other than hypertrophy in of itself. And so that was the essence of that question.
Okay, interesting. Anybody else have any thoughts on that? And please, people jump in too, because we have a lot of smart people on here who weren't necessarily designated to the panel. Just that was my easy, lazy way of getting people to talk.
I could say we have the Owens units, but I have not used that protocol, so I don't know.
So there was a.
Do you mind if I jump in?
Yeah, absolutely, Stephen.
Sorry, that's my study, my research study, that one you were talking about, Eric.
No.
So,
Awesome.
Quite handy. Yeah, essentially we use it for recovery purposes. We find it quite effective in regard to that. It's like anything else, it's just timing and how long you've got from a recovery perspective to use. You know, in all essence, 5 minutes on, 5 minutes off, repeated 3 times, takes up a good chunk of time from a recovery perspective. So it was more a proof of concept sort of idea more than anything. But certainly we feel it's more a little bit like, well, the way I sort of explain it is a little bit around contrast therapy, hot and cold. You've got, when you have cold, you have vasoconstriction. When you've got hot, you've got vasodilation. And this is just an extreme form of that you're using the tourniquet in order to do that. So you're using the tourniquet to vasoconstrict blood flow to the muscle. You release the cuff, you get vasodilation, you get more blood flow to the muscle itself, which is then going to allow for a faster recovery. And that's what we've sort of seen. We've done a few studies that some work isn't published, but similar sort of results coming out.
So where do you think this would be useful? Like, say in a sporting setting, like if I'm on the Tour de France, if I am working with a team, what kind of applications would you be looking at for this type of recovery protocol?
I guess it's just it really depends on, one of the advantages of ischemic preconditioning, obviously it's passive. So you don't actually have to do anything with it. And actually, we know from some of the elite sporting organizations who are currently using it, they're able to do it, for example, on the bus at the Tour de France. They're able to use it very, very quickly without having to necessarily do a lot of it, other exercises as well. So there's also a performance enhancement benefit of ischemic preconditioning also. So if you perform the ischemic preconditioning before exercise, we can also get an enhanced performance. Although most of that work is really around endurance training or endurance performance per se. So again, over here in the UK, there's lots of different organizations are using it before performance itself. And that would be the key thing about ischemic preconditioning is you can either use it immediately before, but it also works for about 24 hours. So there's a lot of people who are using it 24 hours before the exercise to allow them to enhance performance. So there's a few different nuances in the way it can actually be used.
Wow, this is interesting. Thank you, Stephen. Are there any, like I said in there, are there any contraindications? What's the downside that where somebody could take this to, I guess, because it sounds like there's a lot of benefits here. And so if I do too much of it, what are some of the problems around that? Does anybody want to jump in?
If I can go a little bit on that, and then
Yep.
I haven't done the Owens course, so I can be corrected at any time. But
you don't have any research papers on the subject. Come on.
I have my iPad right here. No, I think from what I've seen at least, there do seem to be a few things with regards to individuals with cardiovascular issues. And again, like you guys can give more details, Anthony, and everyone else. But so with peripheral arterial disease and some other conditions, I'd have to pull it up. That's the only thing that I really found. The rest seemed to always kind of compare to the similar risks as to regular exercise. So like they were talking about something like muscle degradation in rhabdo, but then again, that was always basically comparing it to if you do it with someone that's deconditioned and that's in horrible physical condition, and you make them do, I don't know, 3 exercises with 75 reps of each with the blood flow restriction, that may cause issues. But I think that just stands to reason that if someone hasn't done anything and isn't in any way like hasn't trained at all or anything, and you just crush them with volume, even if it is with blood flow restriction, it could cause it to probably be a problem. And I think, as all of you mentioned, we can't load as much with blood flow restriction, right? Like that's going to be a limiting factor. So if we're trying to work on a lot of these other adaptations, more central or maybe more related to, that come with intensity and load, we can't do that with blood flow restriction. So if you kind of see that and say, well, that's great, I can just train at 20% of 1RM all the time and do only that, we're probably leaving a lot on the table with regards to the adaptations that we want to go get. So that would probably be, as you were saying, Derek, like saying, well, this is this new thing, let's just do everything with it. That would be a downside. Otherwise, I don't know if anyone else has seen something else specifically other than the cardiovascular element of it that's contraindicated.
Yeah, no, that's interesting because it is passive. You probably could, like you said, load up on the volume, and it probably wouldn't hurt per se. Does anybody else have any thoughts on that?
Yeah,
because Nikki, yeah, because I mean, being in the exercise community, there's lots of stupid things that people can do. Like they can innovate in ways to create this so that it's harmful. But Nikki, what are your thoughts?
well, so I suppose number one, like if somebody's a candidate for resistance training anyway, then they're probably a candidate for this. So that would probably be your number one filter. In terms of what actually occurs from a physiological point of view, because there isn't really a spike in CK post exercise, as in there isn't really a great deal of muscle damage post PFR because of lower loads that are used. The likelihood of rhabdo, looking at some of the paper, I think the incidence of rhabdomyolysis, for example, with BFR, I think is have been 3 reported cases. So
it's out for CrossFit.
It's yeah, and certain universities, I guess, probably want to stay away from it maybe as well. But and so I think the same, because if you're doing resistance training, you're going to get occlusive pressures in the muscles also. So if you're saying that somebody's clear to do resistance training, they're probably clear to do this. And then it comes down to things like, obviously, people who have certain metabolic conditions, peripheral neuropathies, you're going to be a little bit more cautious with the use, or a little bit more judicious. The usual stuff you're not going to be using on people with cancer and other processes like that. But beyond that, I mean, I think one of the things which is appealing about it is the safety if it's used appropriately and used well. So one of the reasons that I think is key is, instead of just using occlusion wraps or wraps like you'll see in traditional weightlifting, being able to establish an occlusion pressure is important. Being able to use the right type of cuff is important with an adequate width, because the wider the cuff, the less high pressure you'll need for occlusion. So little things like that can also make sure that you're not going to cause some sort of axonal damage to the nerve, that you're not going to cause some sort of damage to the muscle. That's one of the reasons why it'd be easy to say, well, why don't we just wrap somebody up? But we need to at least be a little bit smart in terms of the amount of pressure that we're using, then monitoring the patient. And that's why you sort of think, well, it would be interesting to see it move into performance, or even into sort of more commercial gym environments. I'm sure it probably will. But that's the one reason why I'm a little bit reticent about that sort of thing, is just to give it to somebody and say, well, just throw it on willy-nilly. You don't know. There's obviously been research on the appropriate levels of pressure to use for occlusion. There's research on the actual protocols that you want to use, that you need to be aware of for them to be effective. So those are some of the key things, and one of the reasons why I think it's kind of important to either be trained on it or work with somebody who knows, rather than just trying to invent things with. Because you often see people trying to do plyometrics and other bits and pieces with them, and I think, well, you're not going to get good quality work in those cases. I'm not aware of any research on that as of yet. There might be, but those are kind of my thoughts around that question.
Quick question for everybody: like, where do I learn more? Where do I get good instruction on the use of this? And then some people mentioned a few, I guess, means of doing it. if I want to start doing it, what would you guys recommend that I do in terms of learning about it?
I mean, obviously Stephen has a large amount of research done on it. Jeremy Loenke also, his group, I think it's spelled Loenke. But as far as I'm aware, and I have no disclosures, I think Owen's recovery science is probably the most comprehensive. It's 1-day certification. It's probably the most comprehensive that I've been to, and I've taken a couple. So they do a good job. They're all over. They have courses on every single weekend. But again, it's probably only something worthwhile taking if you actually are planning on implementing it or have the means or funds to actually acquire blood flow restriction equipment, because otherwise it's just an interesting but ultimately useless course.
Anybody else have any thoughts? Go ahead.
Yeah, in the fitness realm, it seems like this really came into U.S. with Johnny Owens and kind of the medical community via that. But this has been around a lot longer in Japan, as known as KATSU training, KATSU. So there's a lot of research on the safety and efficacy in more of the fitness side of things rather than in the medicalized side of things here in the West. So there's a lot of information if you just Google that.
Are there any courses or anything that you've seen on the fitness side?
I'd imagine KATSU does some stuff, but I'm not familiar with it.
Okay. Okay. Well, let's jump to the equipment side. What equipment is available out there right now? Let's start with Anthony. Anthony, what do you know in terms of like hardware? Like if I'm going to get equipment, what's good for me to acquire?
So just like anything in the medical field, there's going to be a different level of things, and some that are quote unquote approved or at a very high price, and there's going to be ones with less bells and whistles that you can kind of pick up anywhere. So really it seems to be the gold standard in the medical community is the one that they're using with the Owen system. It's the Delphi unit. So the Delphi unit is actually it's a surgical tourniquet device. So it has a built-in Doppler ultrasound that is finding individualized pressures for the patients and clients. So within that realm, it's a little more individualized. It's a little bit safer in that regard. There have been a lot of other units that have come on the market at a much lower cost. There's ones that
what
have
would be the rough cost on the gold standard one you're talking about?
It's about $5,000 for the unit. Is that correct, Rob?
Yeah, we ordered in bulk, so we got them for $4,500 a piece. So
yeah.
We ordered a number of units, but yeah, it's $5,000 for an individual unit.
Wow.
Yeah.
So then like companies like go ahead.
No, go ahead, Anthony. Finish.
I was saying companies like Recovery Pump are building their own BFR units. There's a lot of gray area here because I'd like to hear your thoughts on this as well, Rob. The Owens unit markets as being the only FDA approved device, but really from like a BFR standpoint, there doesn't appear to be anything that's actually FDA approved for that. Like that unit's FDA approved to be a surgical tourniquet device, but not for the application of blood flow restriction exercise.
Yeah, I can tell you this. I sat on a panel about a year ago, and the physician for, I can't recall his name, forgive me, but the B Strong unit was on the panel as well as Johnny Owens, and there was a little bit of a discussion, quote unquote, on that topic, and that was the physician's argument with regards to really there's no FDA approval. We got the Delhi unit for two reasons. One, it's the unit that's being used in the research study I previously mentioned, so we had to conform if we wanted to be in the study. And two, unfortunately, in the land of litigation, I wanted to have as many metrics covered as possible. And so those are mainly the two reasons why we got the Delphi unit. I'm sure you can have adequate, occlusion using other units that are much less expensive. But those are the two reasons why we used it.
That's the same reason we got ours, Rob.
Yeah. I have a question just off topic. I've asked Derek this, and during a conversation, this just hit me. So we use BFR, right? And we occlude and we recruit fast twitch muscle fibers, and we wind up with this effect of, whether it's human growth hormone, an anabolic effect in regards to the muscle, the area of the occlusion. Is anybody aware of any, it makes sense to me, but I don't know if it's done or if it's even true. Is anybody aware of anyone using BFR, taking someone through a program of exhaustion? And now you have this environment, this anabolic environment, and the physician draws blood in that environment for use in PRP. Is that blood going to be any better for PRP?
It's like
Is anybody?
blood doping.
I know they're doing that at the Andrews Institute, I think possibly for stem cell.
I'm not aware, but it would make sense to me.
Yeah, they'll do that. They'll do a session, I think, at the Andrews Institute. I think they'll do a session an hour or 30 minutes prior to taking the draw, and I think they're using it for stem cell based on the VEGF1, creating that hypoxic environment with the proliferation of satellite cells, which occurs alongside of that. I believe I don't know what effect it's had in the results, but I was at their orthopedic conference here in Dallas, and they were talking about doing that, and that was what they were doing.
So the draw is after an hour to an hour and a half, or within the hour?
It's within an hour. Let's say they'll do a session an hour prior to taking the draw.
Interesting. Okay. Well, Robbie Bazran, you want to jump in? What did you have for us?
Yeah, I mentioned in the chat, it was just talking about for payment. We at the clinic I'm at, we're doing a 3-year lease, so it's a little bit cheaper in terms of, or not cheaper, but just easier way to pay for it. So that's another option that we've done, because as you know, as I mentioned, it's $5-6 grand. So that's all I was going to mention there, but I put in the chat as well.
And it's probably more expensive Canadian. So yeah, dang.
Yeah, definitely.
Yeah, well, geez, my head's spinning. One thing I wanted to ask, like, obviously, you know, occluding like an extremity is easy. Has anybody looked at torso, pelvis? You know, like if I want to make my abdominals or my spinal erectors stronger, or want them to bulge more or whatever, how would I do that? Is that possible, Rob?
I don't know, but I once had a female patient ask me if it would help with her breast enlarge, and I'm being dead serious. So
New York, of course.
Welcome to New York. I have no idea, and I don't know if I would do it. I don't think I would do anything like that. I think I'd stick to extremity. I don't want to be I'm not going to be the man who breaks ground on torso.
Put K-tip on it.
But I did sincerely get that question.
Really? Wow.
There is some evidence that you can get some improvements within torso strength and muscle mass, but it's mainly due to pre-fatigue of the muscles that are being worked. So
Okay.
so for example, if you're bench pressing, you've got the cuffs on your upper arms, obviously your triceps are going to fatigue, and there is evidence that you get chest cross-sectional area improvements and strength improvements, but it's just because of pre-fatigue. So it all depends on the exercise you're doing. So for example, if you're doing a squat, we also have seen evidence that we see improvements in glute size and strength as well. But if you're doing something which, you know, so the muscles have to be recruited in order below the cuff, in order for there to be adaptations above the cuff, they all have to be intertwined. So you're not going to get any changes in, you know, abs. There's no evidence. There was a study done by a Florida group looking at lower back strength and so on, and they didn't see any changes, and you wouldn't expect to, because you know the muscle's going to have to be recruited for there to be an adaptation. So it has to be involved.
But you would agree that there are people crazy enough who would try it, right?
100%. Unfortunately.
Well, one question I had is, what has anybody found any like research wise any systemic effects? Like, so if I do, say I'm just doing my biceps, like is there any crossover anywhere else?
Yeah, so there's a couple of studies out there. Like, if I'm totally honest with you, I don't believe them. We've done too much work to sort of show that. So, for example, there's a couple of studies that has demonstrated if you do lower body blood flow restriction, you get greater adaptations. If you then do sort of bicep curls and so on, so you get an upper body adaptation from a cross transfer effect.
Mm-hmm.
Now, I can totally buy into the strength adaptation from a cross-transfer effect, because we know that happens neurally. There's some neural adaptations. But the idea that you get a greater muscle mass from something that hasn't been recruited in the exercise. I don't believe, and there's nothing going on there which would make me believe that. Stuart Phillips' lab out of Canada is showing that time and time again that, you know, these circulating hormones, whilst they increase, they are not important for hypertrophy. If they were, we would just have to train one muscle and everything would grow because it was circulating around the body. So there has to be this local recruitment in order to get this adaptation. So for me, the circulating effects are minimal to non-existent, really.
Interesting. The question I had for people was, again, I had in my notes here, like, is it going to be something that's probably predominantly used in rehab, and then you'll have some people trying it, like, obviously for recovery? Do you think it's going to grow in terms of like personal trainers doing it, even strength coaches using it a lot more? Where do you guys see this going, Rob?
I don't know, but whoever using it better have some common sense and have at least some little bit of training in it, or work with someone who's been using it. And I state the obvious, but that doesn't always occur. Like anything else, you know, the snowball's going downhill. Where it winds up, I don't know, but I could see it happening. Absolutely. Yeah.
Anthony, do you have any thoughts on that? Like, you'd obviously mentioned the fitness people were doing it previously. Can you see some growth of personal trainers and fitness people using it, and even, like I said, performance strength coaches?
Sure, yeah, I agree with Rob. Anytime I think it becomes more mainstream, I think you're gonna have more people playing with it. And like Rob said, there are certain, you know, precautions and contraindications to it. So it kind of is worrisome to have a tool like that going out, where I think in a relatively healthy population, it's something that, if done well, it's been shown to be very safe. But you know, a lot of times there's things that are happening that are maybe not the right protocol, or maybe using the wrong tools, or you know, you see guys just taking a band and putting it around their arm when they're in the gym and doing curls, and that could, you know, lead to some neural damage and some long-term issues if it's not done appropriately. So I always think about what Mike Boyle said: just whatever you're doing, pretend you have to explain that to a jury, and use your judgment based back that way. So.
Awesome. I've never heard that. That's good. Jordan, you got any thoughts on, you know, moving forward with this stuff and recommending to others?
I think it has an interesting place with, it maybe comes back a little bit to the equipment question you were asking.
Mm-hmm.
I don't have a Delphi unit because, as you said, you know, we're broke here in Canada and the exchange rate is horrible.
Well, Montrealers are just cheap. Come on.
So like the ones, and actually it's Anthony that suggested those to me to look into them. What was the name? So the ones that I have are smart cuffs. I think Greg mentioned those as well in the questions. And I had used before another one that's called the occlusion cuff. And the reason why I switched a while ago now is that the smart cuffs have a Doppler so that you can actually find what the arterial occlusion pressure is. Otherwise, it's very, very, I find it's very hard to find the pressure at which you have to do it. Not only is it like a little bit less legit, but quite a bit less legit. I think oftentimes you either overshoot or undershoot the pressure. And oftentimes I think I was overshooting it because people don't know what a 7 on 10 of maximal tolerance of occlusion is, because unless you like to strangle yourself, you don't know what that is, what the 10 on 10 is. So, but anyway, so all of this to say, with regards to logistics, I think it's not always easy to do. Like I don't have, in order to do it, let's say within a training session, if I think back to like where I work, I think it would be hard to include into a training if the coaches were to do it. If you have a lot of time and you're seeing, you know, with some of these people that see an athlete for multiple hours, I think it could very well be done. I don't see why not. I think you just, as everyone said, use common sense and, you know, not be an idiot as you use it.
How much time does it take out of your typical use, like session? Like when you say, I'm going to use it on this person, how much time does that take in your
to like set it up and take it off type of thing, other than
like
the exercise part?
Just from a time point of view.
It's not super long, but I basically have to, if I'm in the gym, I usually get out of the gym because it's too noisy for me to actually get the reading and hear the blood flow and kind of find the pressure. So I have to leave where I am, go to the room, set them up, put a bandage around the leg so that it's not just on their skin if I need to. Ultrasound gel, put the Doppler on, find the the blood flow. In some cases, it's a bit harder than others. So it does take, I don't know, maybe like 5 minutes to set up and take down in total. It's not crazy long, but it is something that requires a bit more logistics than just going on, okay, let's go to the next exercise and then carry on. And I think you need to, again, like I think it's been a lot more useful for me since I'm able to find the blood pressure I need to put it on, the pressure I need to put it on, whereas before I used to just wing it and I didn't get as good of a result, or it would be really uncomfortable. Yeah.
How much is the smart cuff unit that you're using?
It's a few $100. I think I got 2 and it was something like around 500, something like that. I can find it here.
And that's compared to 5,000? And that's a reasonable...
Yeah, so 2 cuffs is $350 US. And does it come with the Doppler? I think the Doppler is another so I think it comes down to about maybe 500 US or something like that, 5 something for 2 cuffs. And if you want more, obviously you can get more, which is also interesting with the smart cuffs because you could potentially put 2 on. From what I understood, the Delphi unit doesn't allow that. You can only have 1 cuff on. So let's say on one leg. If ever you do want to do barbell curls with 2 cuffs on your biceps.
Okay, good to know. Nikki.
Mind if I jump in real fast?
Yeah, go ahead.
Yeah, I got the smart cuffs as well, and I got the clinical set, and that comes with the Doppler and the 2 pairs of each side of the cuffs, and that's $1,500. So from a cost standpoint, it's solid, and they're technically also FDA approved as well.
Interesting. Okay, that probably makes it a little more affordable for people to at least
Right.
get into it, get started with it. And would you say in terms of the time that it takes to set it up, do what you want to do, not too much of a commitment?
It's not too bad, but the Delphi definitely is faster. Because it does a lot of that stuff for you. So there's that give and take. And in my opinion, in the perfect world, you'd have both. To kind of set up, figure things out, and then the smart tools is good for travel on the road and take them out to the court. It's much more convenient and flexible from a functional standpoint.
Okay, good to know. Yeah, so we're about an hour here, and I think there's a lot of information that's probably going to, for the people who haven't done it, probably make them look into it. Any final thoughts? Nikki, I'll get you to start on the whole BFR thing.
Yeah, I was only really first exposed to it 2 years ago, just coincidentally, although he reluctantly came on the call in the end. But I saw Stephen present in Belfast, I think it was 2017 or 16 at a conference. That was really the first time I'd had any exposure to it myself. So it's been a sort of slow, well, not that slow, I suppose, but it's just been a road of learning about it, getting as much information on it as I can, and just trying to be as objective about it as possible, not going outside of the parameters which are recommended. I'll leave that to guys that are working with the professional teams, I guess, because they seem to like to take those sorts of risks. I prefer not to, and still learning more and more about it. I think the positives, or the positive side to it, far outweighs the negative. But again, it's another useful modality that I think is going to stand the test of time. And there's some very good researchers that are producing a lot of really good work on it, consistent work, and it's very clinically applicable, and it seems to be effective. So I'm looking forward to continuing to use it and continue to hopefully expand my knowledge base on it, to share ideas with people.
Yeah, and in the chat, just in case, and if you didn't see it, Stephen Patterson put down his email, and he has some information on protocols and papers and things. So I would probably follow up on that. That's pretty useful having him on board. Anthony, what are your thoughts?
Sure. I think overall what we've touched on today is basically big picture. In a scenario where we can't load, if we can't load at a volume we like to, it's a phenomenal tool to kind of be a backdoor around to get the stimulus we want with a lower relative intensity and without the weight-bearing effects. Like Rob said numerous times, we need load. Load is paramount. So as soon as we can do that, and as soon as we get to the point where we can train around 80% of 1 rep max, really this tool, from what I've been seeing, whether it be, unless it's being an adjunct for some sort of volume stipulations, really is not this panacea. It's a tool that's good for what it's useful for, and after that, you kind of move on and get back to regular training. So really, I think when used in that context, it's phenomenal.
Great. Rob, any final thoughts?
No, I agree with Anthony and Nick. Nikki, it's something that's used. I look forward to continue its use and see how it evolves. And like every other tool, it has its proper place. And we just keep using it and see how it goes. But I agree with both it said. Feel the same way.
Great. Jordan, any final thoughts before we sign off?
Mostly the same as what everyone said. I mean, I think it is something that we need to be more educated on and need to educate others more on. I think what Stephen made a very good point with regards to the studies and what we can trust and what we can't trust. And I think when we have something new coming out, at least that's what I have an issue with that where I work, is that people tend to see it as like, oh, this is just another tool, another gadget. And it's the same when you come up, start to use more EMS or things like that. And I think if it's well used, it checks a box that not a lot of other modalities or not a lot of other training methods seem to touch. So to be able to use that a few days after an ECL is something that, other than probably EMS, nothing else can really go there. So I think it kind of fits in that box. And as long as we make that clear, and that it's not going to replace everything, it can be very interesting to use it in a lot more cases than what we see right now.
Awesome. Thank you, everyone. What I'll do is some people jumped on later too, so I'll just make sure this whole thing is published in its entirety so that people can catch up on it, and certainly was useful for me. I didn't realize one, how extensively it was being used, and that it really is beneficial and isn't going to cause a lot of problems. So thank you once again, and hopefully you guys can enjoy the rest of your Sunday. But thanks for jumping on, and we'll be trying to keep doing this at least for the next couple of months. We'll get a good topic for next week. Okay. Thank you very much.
Thanks, Eric. Have a good evening.
Thanks, everyone.
Take care.
Thanks, guys.
Good night all.